Hi everyone, my name is Michael. I am an internal medicine physician currently working as a hospitalist. This is my first in a series of lectures on common hospital problems, which I hope will better prepare medical students and residents for treating patients in the hospital, as well as help you on your boards. I encourage you to pause the video whenever I ask a question and try to come up with the answer before you move on. Active participation is the best way to learn. Any constructive criticism is greatly appreciated. Please put it in the comments below and I will try to adjust any of my future videos. And now let's jump right into it by starting with a problem. Pause, read, and then move on. Based on this problem, what would you say this patient has? If you are saying sepsis, then you are right. It is likely sepsis. But what does sepsis mean? Sepsis is a systemic inflammatory response due to a presumed infection. It means that the body is having an extreme response to the infection. And how do we identify sepsis? There are a few criteria that can be used. One of the most widely used methods is the SIRS criteria. So pause the video and see if you can write or state the SIRS criteria. Okay, there are 4 criteria. Temperature less than 36 or greater than 38, heart rate greater than 90, respiratory rate greater than 20, and finally a white blood cell count less than 4,000 or greater than 12,000, or immature bands greater than 10%. Now, if you meet 2 or more out of the 4 criteria, plus a source of presumed sepsis, then the patient is considered septic. Now, going back to our problem, would you say that the patient meets the SIRS criteria? And if so, what criteria does he meet? He has a fever greater than 38 and a heart rate greater than 90. Finally, his white blood cells are greater than 12. He meets 3 out of the 4 criteria, although we only needed 2. If we can get a source, or at least suspect one, we can label him as septic. Blood pressure and hypoxia are not part of the SIRS criteria. And although respiratory rate it is less than 20 in this patient, so he does not meet the 4th criteria. Okay, here are what I consider to be the most common sources of bacterial sepsis: pneumonia, UTI or pyelonephritis, skin and soft tissue infections such as cellulitis, erysipelas, or abscess, intestinal infections such as diverticulitis, and abdominal infections such as SBP or spontaneous bacterial peritonitis, hepatobiliary infections such as ascending cholangitis or cholecystitis, and then the less common sources such as osteomyelitis, septic arthritis, meningitis, endocarditis, and endometritis. Finally, don't forget about viral infections, fungal infections, and imitators of sepsis, such as DVT and PE. These are not the focus of this lecture, but they are important not to forget. If you have a patient with upper respiratory symptoms, get a respiratory viral panel. If you have an immunodeficient patient or someone who recently traveled to endemic areas, get fungal blood cultures and markers. And if you have an immobile or minimally mobile patient who meets SIRS criteria, is hypoxemic, but the chest x-ray is negative, one thing to consider is getting a CT angiography of the chest to rule out pulmonary embolism. Now we will go over how to identify each source of sepsis. What is the gold standard test for diagnosis? So pause, write down what you think for each source, and then play. Okay, starting with pneumonia, remember it is a clinical diagnosis. Chest x-ray and sputum culture are useful, but they are not the gold standard test. They are just pieces of the puzzle. In the end, it will be up to you to come up with the diagnosis based on synthesizing the data. Next is UTI. First, get a urinalysis. If the patient has a Foley catheter, remember to first exchange the Foley catheter before getting the urinalysis, as many times the Foley catheter has bacteria growing around the catheter itself, which will lead to a false positive. If the urinalysis is positive for a possible infection, then obtain a urine culture before starting antibiotics, which is the gold standard test. A urine culture growing greater than 100,000 colony-forming units, aka CFUs, is indicative of an infection. A urine culture growing less than 100,000 CFUs, or with no growth, makes a UTI unlikely. Next is skin and soft tissue. Once again, this is a clinical diagnosis, mainly based on physical exam. Although ESR and CRP are useful, they are general markers of infection and will be elevated with most infections and inflammatory states. There is no gold standard test. For the intestines, it is once again clinical. Useful tests to get would be a GI PCR and possibly a CT abdomen and pelvis. To test for an abdominal infection, such as SBP, you will test acidic fluid with a paracentesis before starting antibiotics. If the fluid analysis shows greater than 250 PMNs, then you have SBP. For hepatobiliary, you will typically see elevated bilirubin and ALP on your LFTs. Right upper quadrant ultrasound will show you either cholecystitis or a dilated bile duct, which will prompt you to undergo an ERCP, which is both diagnostic and treatment for ascending cholangitis. Osteomyelitis is often suspected by seeing a lesion that probes to bone on your physical exam. MRI is often done to confirm the suspicion of osteomyelitis, and bone biopsy is the gold standard test. Septic arthritis is diagnosed through arthrocentesis, which would show greater than 2,000 white blood cells with 75% PMNs. Gram stain would be positive for bacteria. Meningitis is diagnosed through lumbar puncture. Endocarditis is diagnosed typically through Duke's criteria and TEE, as it visualizes valves better than TTE. Finally, endometritis is a clinical diagnosis, although endometrial biopsy may be a useful tool. And remember, you want to check a CBC, a chemistry panel, 2 sets of blood cultures, and a lactic acid on all of your septic patients. Now we will talk about treatment. The mainstay of treatment for sepsis is 3 things: source control, IV fluids, and antibiotics. Your source control is about taking out any bacteria that is walled off. That means draining an abscess if there is one, or removing a stone if there is one in the urinary or biliary tract. IV fluids will be discussed later. Finally, an antibiotic treatment. When determining choice of antibiotic, you need to ask yourself, what organisms are you most worried about, and what antibiotics can you use to treat them? It is important that you do not try to treat everyone with broad-spectrum antibiotics, and rather just to tailor it to their source. Imagine we are talking about a patient who has not been hospitalized for years and has no reason for resistant or abnormal infection. What bugs would you expect, and how would you treat each of them? I think of bacteria as divided into 6 major categories. Now, there is no 100% right way to break down categories of bacteria. And of course, there are exceptions to these rules, especially if the patient has previous microbiology culture data that shows bugs with resistance to certain antibiotics. But for a new and antibiotic naive patient, I like to break down bacteria into 6 major categories: gram positive except for MRSA and Enterococcus, gram negative except for Pseudomonas anaerobes, atypicals, MRSA and Enterococcus, and finally Pseudomonas. From there, I can figure out what antibiotics to use because most organisms in these different groups will be treated with the same antibiotics. So, take a moment, pause the video, and write in whatever antibiotic or antibiotic groups you would use to treat each infection, then play. Okay, ready? Let's go. So, gram positives, excluding MRSA and Enterococcus, are treated with most antibiotics. The issue is when you are only trying to treat gram positives. Then, you can typically use first and second generation cephalosporins, most commonly cefazolin. Second, gram negatives, excluding Pseudomonas. For this, I most generally use ceftriaxone, which is a third generation cephalosporin. The beauty of ceftriaxone is that it will also cover most gram positives except for MRSA and Enterococcus, making it your antibiotic of choice for most cases of sepsis until you can isolate an organism. An added bonus is that it is not renally cleared like most other antibiotics, so you don't need to worry if your patient has AKI or CKD on changing the dosing with ceftriaxone. Third are anaerobes. For that, it's dealer's choice between metronidazole and clindamycin. I prefer metronidazole, and can anyone tell me why? It's because clindamycin is highly associated with C. diff, so I like to try to stay away from it. Next are atypicals, which are typically treated with azithromycin and doxycycline. MRSA and Enterococcus are going to be treated with vancomycin most commonly, although linezolid may be used in cases of vancomycin-resistant Enterococcus, better known as VRE. Very quickly, just remember that when de-escalating vancomycin into an oral regimen when discharging the patient, please remember that vancomycin oral is a completely different indication from vancomycin IV. We are talking about vancomycin IV here to treat MRSA and Enterococcus. Vancomycin orally is only used to treat C. diff and C. diff alone because it is not absorbed through the GI tract. Finally, you have Pseudomonas. It is best treated with a 4th generation cephalosporin such as cefepime, also zosyn, carbapenems, and fluoroquinolones, which always end in fluoxetine, can be used as well. And that's how I break down the bugs and their antibiotic management. It's not a full list, but it covers most sepsis problems. And here's a list of what we just went through. Important to note that not all carbapenems and fluoroquinolones work on Pseudomonas. Avoid ertapenem and moxifloxacin. So once again, back to our old chart, but now we will go over the sources of sepsis at a time, and I want you to think of what the most common pathogens and what you need to treat them with. Imagine the patient was not on antibiotics prior to coming in and had no previous culture data. Pneumonia. So, starting with pneumonia, the patient is often hypoxemic, coughing up sputum. You get a chest x-ray with no opacity. Now, what do you want to cover with? Okay, so it matters what bugs you're worried about. The most common cause is strep pneumoniae, which is gram positive. You also need to worry about Klebsiella, which is gram negative, Moraxella, gram negative, Mycoplasma, atypical, Chlamydia, atypical, and Legionella, atypical. Treat with ceftriaxone 2 grams daily for gram positive and gram negative, and azithromycin 500 milligrams daily for atypicals. Next, with UTI, Urinalysis has leukocyte esterase, nitrates, and white blood cells. Urine culture is in process. What do you think the possible organisms can be? E. coli, gram-negative, is your number one. Then Staph saprophyticus, a gram-positive. Klebsiella, and other gram-negatives. For mainly gram-positives and gram-negatives, we use ceftriaxone 2 grams daily. Skin and soft tissue infections. Next, these are typically going to be cellulitis erysipeus. We'll see red hot skin. ESR and CRP is typically elevated, usually caused by Staph aureus and or Strep pyogenes. Both are gram-positive, so we're going to treat with cefazolin 1 to 2 grams Q8 hours. If there's an abscess, suspect MRSA, perform an IND, and treat with vancomycin, which is always dosed by level. It's a complicated equation based on weight and creatinine clearance. If the patient has diabetes mellitus and has exposure to water or shellfish, cover Vibrio and or Pseudomonas with cefepime. And a surgical emergency, if you have crepitus, then you suspect C. perfringens, you get a CT scan, and you call surgery stat. Intestinal infections. First, let's talk about the abdominal infections. We said ascites. You got the TAP, you see PMNs greater than 250, then you're going to want to start ceftriaxone 2 grams daily, okay, as it is caused mainly by gram-negative organisms. Hepatobiliary and other intestinal issues, those are going to be gram-negatives and anaerobes, because those are the organisms that are typically found in the GI tract. So most of those are going to be covered with ceftriaxone 2 grams daily and metronidazole 500 milligrams Q8. If C. diff comes back positive, what do you want to treat with? Most cases are going to be oral vancomycin. Okay, fantastic. Osteomyelitis. You have someone with a wound that probes the bone. MRI confirms a high chance of osteomyelitis. You want to cover gram-positives, including MRSA, and gram-negatives. If diabetic, cover Pseudomonas as well. So I would say vancomycin dosed by level and ceftriaxone 2 gram Q12 hours in this case. And instead of ceftriaxone in diabetics, you want to use cefepime if they're a diabetic. Septic joints are a red swollen joint. You do an arthrocentesis, you see white blood cells greater than 2,000 and over 75% neutrophils. They are usually gram-positive, so you want to cover with vancomycin given the high risk of MRSA. Meningitis. Now this one is more difficult, and I plan to go over meningitis in more detail later in a future video. But in most cases, you're going to want to cover with vancomycin dosed by level of ceftriaxone 2 grams Q12 hours, acyclovir dosed by weight, and ampicillin if the patient is either elderly, so over the age of 55, or an alcoholic. And remember, the patient typically should receive a dose of steroids in addition to antibiotics. 9 is endocarditis. These patients will typically have a new heart murmur, a history of valve issues or damage, or IV drug use. The TEE confirms the vegetation on the valve until something grows. You suspect MRSA and you start vancomycin. And finally, endometritis. Now, once again, I have never treated a case of endometritis. As far as I understand, it usually happens postpartum or post-abortion. Suspect if there is foul discharge, treat with clindamycin and gentamicin. One point I'd like to make is that although you don't strictly need an infectious disease consult for any suspected source below hepatobiliary, so osteomyelitis, septic joint meningitis, endocarditis, or endometritis, I would get them so they could help tailor your antibiotics and the length of time that the patient will receive antibiotics. Over 90% of your sepsis cases, though, will be one of the top five. So pneumonia, UTI, skin, soft tissue, intestinal, abdominal, hepatobiliary. But if it's not those, I would call ID. Another point is that once the patient is no longer septic, meaning the SIRS criteria is no longer met, you can often de-escalate antibiotics to their oral equivalents or to a lower dose of IV antibiotics. For instance, pneumonia when no longer septic, UTI when no longer septic, it's not ceftriaxone 2 grams daily anymore, it's 1 gram Q daily. And then finally, we did not go over line infections. If a patient has a PICC line, a midline, or a venous port, you may now suspect a line infection, which usually needs to be removed. Usually they are gram-positives, but they can be anything, including fungal. Call ID in these cases, and call ophthalmology if it's fungal, specifically Candida, as they will need to screen for endophthalmitis. Here's what we just went over written out. I highly recommend that you print out this slide and write out the dosages of certain medications so you know them offhand, especially if you are a resident. Let's very quickly go over severe sepsis, then septic shock. Pause the video, write down the definition of severe sepsis as well as the treatment. Great, so the definition of severe sepsis, it's sepsis with signs of organ dysfunction, hypoperfusion, or hypotension. So a MAP less than 65 or a systolic blood pressure less than 90. And the treatment is antibiotics as outlined before. You can consider broad spectrum antibiotics depending on the clinical scenario, as well as IV fluids, 30 cc's per kg of the patient's weight within 1 hour. Now, once again, pause the video, write down the 5 signs of organ dysfunction, as well as what to do after you give IV fluids. Great, so lactic acidosis, AKI, elevated liver enzymes, when they're not the source of infection, so not ascending cholangitis cases, not acute cholecystitis cases, altered mental status, and significant troponin elevations. Those would all be signs of organ dysfunction or hypoperfusion. And then after you give treatment with the 30 cc's per kg, then you want to recheck the lactate. If it's not downtrending, if it was elevated, then that might be a sign of worsening status and the patient might need more fluids as well as an ICU consult. Now let's do the same for septic shock. Pause the video, write down your definition as well as the treatment. So septic shock is severe sepsis, but the patient remains hypotensive even after the fluid bolus. The treatment is broad spectrum antibiotics, so vancomycin and Zosyn typically, or vancomycin and meropenem, and vasopressors to maintain a MAP greater than 65. So now pause the video one last time, write down as many vasopressors as you can. Great, so norepinephrine, vasopressin, phenylephrine, dopamine, and epinephrine. The first one always is norepinephrine, also known as Levophed. Okay, and that's going to be during your ICU rotations. Now let's go once again back to our problem. We have already said our patient was septic, but based on the previous 2 slides, what else can you diagnose the patient with? Take a moment and pause. That's right, the patient has severe sepsis. Although the lactic acid and blood pressure are normal, he has altered mental status and an AKI, assuming his baseline creatinine function is normal based on his fact that his past medical history omits CKD. Now, let's move on to our next steps. Okay, read the step, pause the video, and then write down or state what you think you would be looking for. with each of these studies, as well as what you think the answer is. Okay, a bone biopsy is to rule out osteomyelitis. A GI PCR is to rule out an intestinal infection, such as gastroenteritis. A lumbar puncture is to rule out meningitis. Urinalysis is to rule out a UTI. And then throw the patient in the donut of truth and scan his entire body is just poor management in general, but you'll often see it done. What is the right answer? Well, given that the patient has a Foley catheter, the most likely source of infection is a UTI. And the best way to check for a UTI is first exchanging the Foley catheter and then getting a urinalysis. So E, urinalysis after exchanging the Foley catheter, will be the right answer. Okay, read the step, pause the video, and then write down or state what kind of infection you would use each of these antibiotics for, as well as what the right answer is. UA is positive. Urine culture takes a few days to come back. In severely septic patients, how much LR do you give? That's right, 30 cc's per kg over the next hour. So in a 70 kilogram man, it would be 2.1 liters. And which antibiotic? UTIs are mainly what kind of organism? That's right, gram-negative. So treat with D, ceftriaxone. Ampicillin is used to treat meningitis in alcoholics and the elderly. Azithromycin treats atypicals in pneumonia. Cefazolin treats gram-positives, so mainly used in skin and soft tissue infections. Clindamycin and metronidazole treat anaerobes. Finally, linezolid and vancomycin treat MRSA and enterococcus. Okay, read the step, pause the video, and then write out what you think the answer is, as well as when you would use the other answers. We now have new information. The patient has a urine culture that is growing Pseudomonas, and he is not improving. Does ceftriaxone treat Pseudomonas? No. Which antibiotic does? B. Cefepime. That is the answer. Although keeping the patient on ceftriaxone for a total of 48 hours is typically the right move if we don't have any new information, given the new information, it would be irresponsible to keep him on ceftriaxone at this time. Linezolid and vancomycin are once again used for MRSA and enterococcus. Usually calling consults is not the right answer. You call ID if you are truly stumped, and you call ophthalmology if you are concerned for fungal eye infections for patients with candidemia. And unless your mother is a doctor, she probably can't help you here. Okay, once again, pause the video, try to come up with the answer, and then play. So the patient's improved, and now you want to discharge him on oral antibiotics. Which is the right antibiotic? So which of these antibiotics covers Pseudomonas? The answer is A, ciprofloxacin. The fluoroquinolones are the oral antibiotics that can treat Pseudomonas. Clindamycin is used to treat anaerobes. Doxycycline is used to treat atypicals as well as MRSA, if you need an oral regimen for MRSA. Phosphomycin, nitrofurantoin, and Bactrim are all great antibiotics to treat uncomplicated UTIs in a female as an outpatient, but not good for inpatient UTIs. And finally, our last question. Read, come up with the answer on your own, and play. Okay, so we have kept the patient here for about 5 days, and now he has a new fever and hypoxemia. What do you suspect is going on? Now, unfortunately, this is a somewhat common scenario that we had discussed earlier in the lecture. Given that the chest x-ray and lung exams are normal, I would suspect a pulmonary embolism, or PE. And how do we diagnose this? Choice A, CT angiography of the chest. This is just a reminder to always try discharging your patients as soon as safely possible, as complications will often arise in the hospital that won't necessarily arise as an outpatient. Lumbar puncture and TEE are to diagnose meningitis and endocarditis, respectively. Neither are common to develop as an inpatient. Switching to broad spectrum antibiotics can be done, but it is not the best answer, especially since no source is identified. I would hold off doing this unless I had a larger suspicion of a new infection or hypotension. As we discussed earlier, UA before exchanging the Foley is never the right answer, and a UA after exchanging the Foley would once again be wise, but would not explain the hypoxemia, so it is not the best answer. Finally, you can't call your father, the buck ends with you. I want to end by thanking you all for listening. I hope you learned something regarding sepsis and antibiotic management. I encourage you all to leave your comments at the bottom of the page. Any constructive feedback would be very helpful. Take care, and I hope to see you again.